Everybody, welcome to Town Hall. Thank you so much for joining us. We'll do a little bit of small talk while we wait for people to come on. The panel here and we had a little conversation about how nice the sun is and yet how cold it seems to have turned quickly. So, Brenda, you said that you went into the building yesterday in the mid 60s and came out and it was cold.
Was cold and windy, and then on the drive home started raining. And then there was hail coming down, not in my area, but yeah, fun
I
day.
was I was in Hyde Park late yesterday, and there was just sheets of rain coming, um, and traffic was not so much there, but traffic around the city was a whole snarl. So yeah, but spring again, just cold but sunny today. So when I will put up with a lot of cold for sun. So I'm going to get us started. I want to once again thank everybody for being here with us. I'm delighted to have Julie Creedon. She's the medical director of the RFU clinics at the Child Advocacy Center, and Carrie Flanagan, the executive director of the Lake County Children's Advocacy Center. We have Brenda Affinati, who's our assistant dean for medical student education phase 3, and Jeff Espina, old friend of the town hall, who is our vice president of clinical affairs. So we're going to talk about the Child Advocacy Center and the collaboration with RFU and the clinic there. You've heard me talk about this before and write about it. I write about it again this week. But my other than the fact that I did visit the clinic this week, which will come up in our conversation, but most of the news today, or most of the news from this week, was that we had our quarterly board meetings this week. On Wednesday were the committee meetings. On Thursday was the board meeting itself. This was my first in-person meeting since I interviewed, so that was an interesting new phenomenon for me. I felt really good about the meetings for whatever that's worth. It was also the first in-person meetings, I think, for Jonna and Alex as we were working on logistics, and they did a great job. And Jan Urban's first in-person meeting as well. So the board is being really supportive and good to work with, and we had lots of good conversations. On Wednesday evening, Lee Concha did a presentation about the strategic plan and where we are. I think all but 3 of the goals are solidly in the done category, and we're working on the others. We'll have a town hall about the strategic plan. She also foreshadowed the strategic plan is aging out, so we get to work on a new one. Get to work on a new one. Everybody's always excited by that. But Lee also talked a little bit about that. We'll have, like I said, we'll do a town hall about it and how we're going to involve people. The idea is that we get it done in a shorter time frame than the last time, and we have fewer things that we have to track. Maybe things just as important, but maybe a couple fewer things to track. A lot of the conversation at the board was about budget. So last year's budget projected a $1 million shortfall, and we are just about on track for that. So this constitutes actually an improvement. So people should actually feel good about how we're doing on budget things. The plan from the board and the 5-year plan is that we close that $1 million gap next year. A couple of things have made that more challenging of late. So maybe the largest is the increase in healthcare costs that we pay. A lot of that's pharmacy. So a lot of that is medication costs, led by GLP-1s. We are self-insured, so up until a particular point, that is just money that we spend. So that's one of the reasons why we feel it a little bit more on the budget. The other thing is that we're working with the state on the tax issues for the woodlands. So a few years ago, the whole process for the woodlands to become a part of the university, which is, I think, important for how we engage with students, support student life, also has some financial benefits for us. And we have seen some of those, but a part of the tax piece is not yet done. So we have to be prepared to deal with those, an increase in the tax bill until we get this all sorted out. So those are a couple of things that give us a little bit of an uphill path. On the other hand, enrollment has been good. And we are looking at, our proposed budget so far has a merit raise in it. We're doing our best to keep tuition down for students, as well as closing that $1 million gap. Really important in that whole process is the early start. So we're doing that for a lot of academic reasons that are good for our students, but with the changes in Grad Plus loans and the changes in caps for professional and grad uh, degrees, uh, the early start grandfathers in our students, and that helps us out quite a bit, not only on getting access to loans, but the cash flow that comes from federal loans that comes a little bit earlier. We'll get another chance to talk about this when Gavin talks about the budget, and but those sorts of things have been going well. The other really nice piece is Gavin and his team have done a great job trying to get rid of the covenants on some of our bonds, which required that we put a lot of our endowment in fixed income. And without those covenants, we're a little bit more exposed to the market, which at least until of late has been strong. So the endowment has been doing better than it has in years past. We have a much more modern uh, endowment policy than we used to, which is good for us. The other thing, I talked about fundraising and philanthropy. So the worst kept secret may well be that I'm interested in doing a capital or a comprehensive campaign. And I talked to most of my time with the board was spent on that. We will go to the board in June to talk about it some more. We have hired a set of consultants to help us think about how a comprehensive campaign would work. And we'll end up talking about that more, but that was a piece of a large part of actually what I talked to the board about. All right, I'm always happy to answer questions. Anything that you want to ask about that bit of news or about anything else that we're going to talk about. So feel free to put those in. It's always more fun when there are questions. And Julie, I think I'm turning to you first, right? As we start this off, you are our medical director, and like I said, I was there. I guess that was Monday, I
Yes.
think, right? And got to see the clinic and meet well, I've met you before, but met some of the nurses and the whole staff. And I'm going to just turn this over to you at this point.
Well, thank you. And we thank you for coming to the center to really see the work in action.
Yeah.
And thank you for having us present today to share this journey that we've been on together to integrate Rosalind Franklin University into the Lake County Children's Advocacy Center. This work has been in progress for many years now, led by Senator Morrison and Carrie Flanagan and their relationships in the community and their unwavering commitment to child advocacy. And with Rosalind Franklin, Dr. Affinati, and Jeff Espina all working together to put children and their families first as kind of the North Star of this project. I was fortunate enough to come in about 18 months ago and take the baton and carry us to this announcement and sharing. So thank you to funding from Senator Morrison and managed by Carrie and Jeff to help us create and build the big picture as to how this would come together. So in essence, the purpose of this collaboration is really meant to be the complete and final piece of the puzzle of the multidisciplinary team to increase awareness in the colleges and community, and most importantly, provide trauma-informed care needed for the child victims of physical and sexual violence. You can flip to the next slide, where we talk about the last 5 years, the CAC has been hosting a cohort of students at the center to increase to effort to enhance their understanding of the process involved in caring for these child victims. So our M1 students are able to attend a forensic interview, sit down with the multidisciplinary team, and understand the inner workings and collaboration between multiple entities involved in these cases. Very similar to a care conference in the hospital setting when multiple specialties come together to develop a plan of care and integrate their expertise into the overall treatment plan. The missing piece has been the integration into the medical component, And now, with our fully accredited and approved medical clinic within the center, we hope to soon allow for that observership and eventually clerkships within this setting for those interested. We work closely with the child abuse pediatrician for expert peer review, and we hope that this collaboration and increased exposure will help the consideration of this specialty in our medical students. There are currently 350 child abuse pediatricians in the United States and only 16 in Illinois. So as we expose our students to this type of care and specialty, hopefully this will be an avenue that may be considered within that college. As for the College of Nursing, we hope to increase awareness into the specialty of SANE nursing. SANE stands for Sexual Assault Nurse Examiner and requires additional didactic and clinical training, as well as a specialized certification to care for these children and appropriately process evidence and paperwork to be submitted to the State Crime Lab and the Illinois State Police for prosecutorial evidence. Proper collection methods via a certified SANE can secure the integrity of evidence collection so there is no opportunity for contamination or inadmissible findings. We intend to enhance our work with the mental health department and continue to increase awareness every year during Child Abuse and Sexual Abuse Awareness Month coming in April. We will be on site at times to share our information and support. So in this goal of the collaboration between Rosalind Franklin and the CAC, we certainly hope to influence the colleges within the university. On the next slide, I want to talk about the benefits of this integration model into the multidisciplinary team and how we as the medical team have infiltrated and integrated into their very efficient and cohesive structure and processes. For children going through this without a CAC, it can be very disorganized and chaotic. But in the CAC setting, the entire team is always present and collaborative. The victim advocate is the point person in navigating and coordinating the throughput, along with the MDT coordinator. The forensic interviewer has specialized training in meeting with the child in a comfortable setting, usually with our support dog, Lyndon, if the child would like, and they work to develop the relationships and trust as they allow the child the opportunity and platform to share their experience. The mental health team is always on standby to step in and offer on-site and ongoing counseling, and they have group and private sessions for counseling and therapies. Our law enforcement partners are there and may be the first line of communication from a family disclosing an event, or DCFS has been notified from a mandated reporter at school or daycare to bring the child in for evaluation. The assistant state's attorney are present for every interview in the event that there is evidence that can be charged and prosecuted. When a child discloses physical or sexual abuse, they had to be referred to a hospital setting for medical evaluation. With the Rosalind Franklin collaboration, we are now present and on site to offer that immediate care and evaluation when indicated and necessary. We offer 24/7 availability for emergency situations and collaborate with the leadership team to determine the best course of action for depending on the circumstances. Together, we work to ensure and apply trauma-informed care techniques that aim to minimize the duplication of interview efforts, which reduce the ongoing trauma of these children telling and reliving their experience multiple times to multiple disciplines. If you can go to the next slide. And the one after that. Thank you. So by adding the medical team to the CAC, our medical forensic exam is intended to collect physical DNA evidence in an acute sexual abuse case, which is considered within the first 7 days of assault, offer testing and treatment for STIs, HIV, and pregnancy, and collect photographic documentation of physical injury and provide community referrals when necessary. This medical forensic exam can certainly extend beyond the acute phase and be performed at any time to provide reassurance through testing, exams to children to tell them that their bodies are okay, despite having experienced this trauma, and or to provide referrals and resources when indicated. The intent of this full scope of practice and multidisciplinary team is to avoid the emergency department. Our emergency departments are equipped to take care of trauma patients, stroke patients, other very acute and emergent situations, And though this is an emergency to that family and child, we know that oftentimes they can wait for extended periods of time within the emergency room. Sometimes they have to wait for a SANE nurse to be called in, which can take up to 90 minutes. That's the limit by the state law. And we want to make sure that we can provide care within the setting that they're already comfortable in, with the support of the victim advocate and people that they have already been familiarized with Lyndon if necessary, as a dog companion, and in a very safe, intimate, child-friendly environment with immediate access to our care. Oftentimes, families have been through enough when they come through the center and are not ready to have a medical exam that day, and we have the ability to schedule them at a time that's more convenient for them. So on the next slide, I really just want to focus on how we strengthen these communication, or exactly what that medical exam entails. I think we talked a little bit about it, but that one of the most important things, which is a little bit different from consent within a hospital setting or other consents, is that consent is always ongoing. At any time, if that child ever decides that they're done, we immediately stop that exam. This is a control issue for them. They have had no control over what's happened to them, and we want them to have the ability to have control over their bodies and what's being done and what's being said. So their disclosure is at their willingness, their exam is at what they are willing to have. So we do a thorough head-to-toe exam, collect that evidence, submit it to the state crime lab, prescribe medications whenever it's necessary, and make sure that they have the necessary resources and referrals for ongoing care. One of the delays in this process was getting what's called a Medi voucher. A voucher is a coupon that we give to these patients to allow them to have 180 days of free care for whatever they need after they have disclosed this trauma. Being a new pediatric healthcare facility, it took us a little while to be able to institute this process, which is governed by the law, the SACITA law, which stands for sexual assault for survivors of this type of trauma. And in that act, we provide them with this ongoing care to help them get through this time frame. So this is the process that we are able to provide in real time within our setting so that children and families can experience this in one comfortable, safe area. As we work together, in the next slide, to share this information with our multidisciplinary team, we really focus on a standard of communication so we maintain the integrity of the information sharing, so not to compromise the prosecution and law enforcement aspects, and encourage this ongoing dialogue to be able to ensure complete, accurate transfer of information. We work together as a team. We feel like Rosalind Franklin being integrated into this team has put that last puzzle piece into the component so that we're all working together, rowing in that same direction, taking care of these children and families. So I hope I've described our clinic a little bit, the collaboration between all the teams, the work together with Rosalind Franklin and the state's attorney's office and the Children's Advocacy Center, and the multiple people that we need to thank in bringing this all together to be able to care for these children. So I hope that, if Carrie, Jeff, Dr. Affinati have anything to add, we can answer any questions for you as to how this is going, how it came about, where we are, what's going on. Thank you.
Carrie, maybe you can tell us just a little bit about the CAC itself and where it came from and the overall work that you guys do.
Sure. Thank you so much for having me here today.
Sure.
The Children's Advocacy Center in the state of Illinois, there is a Children's Advocacy Center in every county. So anytime law enforcement respond to a child under age 18 where there's been any allegations of physical or sexual abuse, they have the opportunity to be brought to a Children's Advocacy Center. We are the only Children's Advocacy Center in Lake County. Cook County, for example, has approximately 5. There are 41 Children's Advocacy Centers in the state of Illinois. For anybody that practices outside the state of Illinois, it's the same in every state. We are all accredited through the National Children's Alliance. This year, we went through our reaccreditation where we are obligated to make sure that all of the different disciplines have not only the correct training, but that we're following the same model. The model being that children who disclose are brought to this environment where, as Julie pointed out, all of the different disciplines are present so that a child would have to tell their story not multiple times to multiple people in order to be able to get the facts of what occurred. Obviously, the goal of every particular discipline is the same, and that is the safety of the child and the well-being of the child. So the addition to the medical is a huge piece of, quite honestly, our success. Most centers throughout the country have a medical component. In the state of Illinois, we obviously being the first pediatric SANE clinic to be approved is a huge accomplishment in setting the path for other centers throughout the state of Illinois. I think as Julie pointed out, our team really works together to make sure that the questions and the concerns are being addressed. A child is brought here to be interviewed in a separate room while the team observes on a live feed. So the only person that is in the room with the child is the forensic interviewer. However, the child is aware of the fact that other team members are observing the interview, and breaks are taken throughout the interview to make sure any questions that need to be addressed by particular disciplines are addressed in a timely fashion. The children that come through our doors, we are, for example, a non-for-profit, a 501c3. So we have the opportunity to raise funds, but also unique to us is that we're also a division of the Lake County State's Attorney's Office. With that being said, these children are afforded a lot of different services. Our mental health team, free support for them, for counseling to prepare them in the event that the case is going to trial, or just to help them on their journey to alleviate the trauma that they've experienced. And then, of course, things like support for, clothing and toiletries and things of that nature when children are being placed in a different environment. So the team is working in conjunction with each other all the time, again, to address the needs of the child.
That's great. So actually, Hector Rosgato has a question maybe related to this. How do you deal with cultural sensitivity issues or non-English speaking families?
Oh, thanks. That's a great question, Hector. We have one of our interview rooms is equipped for telehealth, or I should say a tele communication, so that if there is any interpreter specifically of languages that we don't have on site, we would want to make sure that that's addressed in a timely fashion. We have on site, a majority of our forensic interviewers all speak Spanish, which is a huge piece of our population that we see, in addition to other team members that speak different languages. But no child is ever turned away based on a language barrier. We have access to that immediately. Any person that's in the waiting room, all of our team are equipped with, for example, iPads that allow someone to come on live to be able to communicate with the children that are coming through our doors and or the families that are in our waiting room.
Sort of like in a hospital situation or clinical situation.
Exactly.
Or any other clinical situation, yeah. So Brenda, Jeff, you guys have been involved in this for a long time now. Like, how'd that happen? What did that look like to you all?
Brenda, why don't you start, and then I'll take over from there.
Well, I guess it's kind of a funny story. This is, I guess, how innovative things start. I was at the dentist, who's Carrie's husband is my dentist, and he was talking to me about this medical clinic that the Children's Advocacy Center was working on, and I was like, "Tell me more," as he's numbing me up, and so he starts.
You
talking
really sort of
about,
said, "Tell me more." Is that what you're saying?
yeah, exactly. As he's
Okay.
the needles, and I don't like needles. I'm an internist. I don't see blood. So, but afterwards I was intrigued because I was at the time associate dean of clinical affairs, trying to find clinical opportunities for our students, and here I'm hearing someone say 5 miles away they're trying to open a medical clinic. So boom, right away I'm excited. After the appointment, I called Carrie, and she starts telling me everything, and I'm like, well, what's a SANE? What's an advocacy center? I didn't, as an internal medicine doctor, again, I was never exposed to that. And all I'm thinking is, wow, our students need to learn more about this. They need to get involved with this, not just for the clinical opportunity that would be in the future, but for these forensic interviews. So I went up and did what you did, Erin, is spent the day with them and did forensic interviews. And I just humbling and just so impressed with the sensitivity of it all to
Mhm.
the victims, and of course playing with the dogs, and thinking about that, we had at the time, Dr. Regina Gomez was coming in charge of Clinical Foundations of Medicine, which is one of our courses in Chicago Medical School for the first years. And I was like, well, that's low hanging fruit. We can set up a observership for those students to come through. So that's how we started the very first year. We had about 35 students come through, and a lot of, scheduling, and because the students don't have time to go over, but the ones that did, they really were impressed, and they learned about advocacy. And the other thing is learning about the law enforcement and then the judicial system on the future, their future career, so that when they're in a situation like this someday in the future, they're not shying away from it. That's
Mhm.
one thing the law enforcement was saying consistently was, these doctors don't respond. They don't want to respond to these subpoenas, and how important it is for the doctors to come and testify when it's appropriate. Doctors, you're not being sued. This is for advocacy for
Mhm.
the children we're trying to support. So luckily, also at the time, this is like the perfect triad. Is Jeff Espina was relatively new. I knew him. He was probably a year or so into
Mhm.
the job, and I was like, "Gosh, I know this guy who's really creative. He's in charge of our medical." And so all I had to do was bring Carrie and Jeff together, and then it was magic. So, because Jeff thinks out of the box, he's innovative. He was open to the idea immediately. And then when Carrie reached out to Senator Morrison, then the whole thing really took off because we got the financing to help us. So, Jeff, what about your point of view?
Brenda, thank you. That was very, very kind words. I'll send you your check later for those support. But yeah, so gosh, when this was about a little over 2.5 years ago is when this discussion actually happened with Carrie. And like most of everyone on on this town hall, it's like I didn't know what a SANE was. I didn't know what a CAC was. And so meeting with Carrie, getting a better understanding of what's happening out there in the community, I was floored. I was floored because I've been in healthcare administration for 20 plus years, and I'm happy to announce that publicly. But I've launched hospital services, obviously with the hospitals. I've launched medical group office, physician practice specialty offices in the course of my career, and I was flabbergasted that no health system has actually stepped up to assist with this patient population. For me personally, I went into healthcare because I want to make a difference with the community. All of us have different reasons for being in this field. Mine was because I did want to make a difference. And joining Rosalind Franklin University and taking on the health clinics and doing what we have done here, I'm always thoughtful and mindful about what the next step is going to be and what can we do in our clinics that is going to support the community and the mission of our university. And so when Carrie and I spoke, my heart just dropped. I said, why wouldn't I try to make this happen? Why wouldn't we try to figure out how to make this work? This seems to me that, the wheels just kept turning, and Carrie and I just kept talking about what needed to get done. And then the big factor in getting us to move forward is to get Senator Julie Morrison involved, a huge advocate for for children welfare, and so we needed to bring her to the table because launching a program like this that's new to the university, new to the health clinics, required some thought, required some planning, and required quite frankly some funding because I did not want to burden the university with launching a program that would require some financial help to get this program going. And Carrie's been amazing and fantastic and supportive. We pulled Senator Morrison in, and Brenda was at that meeting, and Nick Helleris. So Senator Morrison asked me, Jeff, what do you need? This is something that this clinic has been sitting 5+ years not being used. What do you need? And I gave her dollar figures, like, give me 2 weeks. 2 weeks later, we get an email from her. I have funding for you. And we were just very happy, and we've had some challenges working with different state agencies to get the program to fully launch, but we've overcome those hurdles, and so we're very happy to be where we are today to actually start getting and giving these kids the care that they deserve. it's not what they need, it's what they deserve. These poor children are going through such a traumatic period right now, and the last thing that they need is trying to figure out who's going to take care of them and how they get their care. And that's our job as healthcare professionals, is to figure that out for them. And I feel like we did. I feel like we have. And this is just a start of the program, or just the tip of the iceberg. I think Carrie and I were trying to figure out what that phrase was. It's just the tip of the iceberg of what we're trying to do here. And things have started to move since we started to become more visible and create more awareness. So I'm very happy and ecstatic of what this program is going to bring to the organization and to the community.
It is an interesting sort of set of collaborations, because there were other, I don't know, healthcare entities who might have stepped up to do this, but it was some combination, right, of Jeff, Nick, Carrie, Brenda, everybody, and Senator Morrison finding a solution that hadn't previously been found. And I mean, often that is the way innovation happens. People find something that hasn't been found before. Carrie.
Thank you for pointing that out, because I think that's huge. I think that for me, when we were looking at outside entities to be part of this program, what I learned in my years of trying to seek a partner, specifically local hospitals, for example, was that it wasn't a matter of not thinking that this was important or not wanting to necessarily treat these patients, but just simply a lack of understanding what a children's advocacy center was. And I appreciate how humble this panel is, and just identifying the fact that being in internal medicine or practicing out in the community for years, not understanding what a SANE exam was. And it was at that point in time that really looked at, we need to start with our students. We need to educate our students on what it is. If indeed, for example, RFU is sending these, future doctors out into the world, that they should know. Because whether you're in an ER, whether you're in a pediatric office, whether you're in just a general internal medicine, you will come across somebody who has been abused, somebody who will need to understand what these services are. And that in itself makes a difference. So hence where we got started with the M1 students and bringing them through, starting down there, and then really growing that program to where we are today. So I think it's important. It's not simply a lack of, obviously, people not wanting to be involved, but really shows the importance of educating our community on the work that we do.
So, Julie, can you talk a little bit about what happens in the clinic? Like you did mention this, but I know that it's not all exams. I mean, people get called, you get consulted, sort of. I mean, like what are the sorts of things that our nurses do?
So thank you for letting me expound on that. The greatest opportunity that we have is to meet these families during this crisis and give them support and offer them medical assistance if necessary. Oftentimes, families may disclose touch that would not necessarily instigate this entire exam, but it helps the children and the families feel that their bodies are okay. So when we can explain to them what a medical forensic exam is, and the opportunity for us to be able to examine them, to send any testing that might be necessary, it can really put their minds at ease. We know that children don't always disclose immediately after something's happened. It can be 2, 5 years, any amount of time later. And we still want to provide them with that reassurance that their bodies are okay and that we are there for them and that we have resources to help support them. So we perform far more consults than we do actual exams in meeting with these families to let them know that we are there for them. We certainly don't want to plant the seed that if anything happens again or in the future, they would come back. But in the event that that does happen or there is ongoing trauma, we want them to know that we are there and available and a resource. So that's been really helpful in being able to allow families to have that experience. Within the clinic setting, it's very similar. We do a very normal exam head to toe. If we see injury, we're able to take pictures. If I can share a couple patient case stories that have been really helpful in the multidisciplinary team, we had a child who came in for an abuse evaluation. She never disclosed strangulation or what children call choking until she was in our clinic. We were then able to apply our strangulation toolkit to be able to ask her all the appropriate questions, and we're very concerned that she had more injury than we could ascertain within the clinic setting. And we're able to then transfer her to a higher level of care where she could get the imaging that she needed. But in disclosing that and sharing that through our process of communication and information sharing in the multidisciplinary team, law enforcement was then able to go out and charge the mother with strangulation. So that happened all within that one clinic visit. And so to be able to see that full complement of practice and everything move into place the way that it should, protecting that child, which is the ultimate goal, and getting her the level of care that she needed, really brought the whole picture together for me. And that was one of our very first cases. We also had a patient disclose that she had been assaulted 2 weeks ago to her father. When she came in to see us, she was able to share that it happened again 2 days ago. That allowed us the opportunity to collect evidence for HIV. Unfortunately, she was positive, and we were able to start that prophylaxis, get her hooked up with the health department, with their infectious disease team, and really be able to care for her in real time, in the right amount of time to hopefully manage her, as well as then providing all the other supports with mental health and those sorts of advocacy efforts. So every day is different. One of the things that Carrie and I talk about on a daily basis is that medicine can be very algorithmic. We like to follow our evidence-based practice and what happens. And in the Advocacy Center, I have not in one scenario heard the same story twice. It is always a different presentation, different confounding factors that come into play. And so as much as we would like to have that cookbook recipe of what to do when, oftentimes we have to pivot, we have to work with the team, we have to be as flexible as we can to be able to provide the care from every angle and every discipline to that particular child and their family. And that's been a fascinating change in my clinical practice, as well as even from a leadership standpoint in working with the multiple disciplines.
So when I was there this week, I met folks from the state attorney office. There were several of them. The state attorney's office also provided mental health services that also the CAC, like it was kind of an interesting kind of group of services that were available. Most curricula for nurses, physicians doesn't include dealing with lawyers, law enforcement. By and large, we stay away from that as much as we can.
Yes.
So, like, tell me a little bit about the, you know, obviously you had to learn those sort of pieces. What's that like? What's that set of, I don't know, duties, responsibilities? What's that like?
That has been a fascinating component of learning this role. And when I originally met with Jeff interviewing for this position, he asked me, "What do you know about SANES?" And I said, "Oh, I know a lot." Well, lo and behold, what I knew was very, very minimal compared to what what I've learned in the past year and a half.
Mhm.
And that being that multidisciplinary approach and really understanding the lens that we all look through. So the state's attorneys are looking through this lens of how can we prosecute the bad guys, right? And that is their only one and only focus. From a medical standpoint, we're looking at how we can care for this patient and their family. And so each discipline has its own set of rules, regulations, guidelines, protocols that they need to follow. And so it
Mhm.
has been a great opportunity, I would say, for both Carrie and I as leaders to make sure that we're supporting our teams, helping them learn how each discipline works and what their needs are, and creating that open dialogue amongst the teams to best put the patient as our North Star. That having been said, I am learning a lot about the rules and the legalities of things, of what can and can't be said, these hearings that happen, how things are presented to the judges, so that the judges don't think that some of the information is hearsay, and that we have really been very intentional about separating church and state, in that the medical clinic is run by RFU, the Advocacy Center is run by Carrie and the state's attorney's office. They're all state's attorney's employees. And that separation, we know where those boundaries are, so that we don't ever want to overstep our boundaries and, God forbid, contaminate the evidence that we are trying to share. So that has been fascinating in working with the attorneys, with the law enforcement, with DCFS, and staying within the confines of their guidelines while trying to implement our guidelines and needs.
So I'm going to just take a moment and deal with and clear some questions that are here. So David Harrison just says, thank you for bringing this collaboration to RFU, really important work. And then Anonymous asks me, what's your reaction to the news that medical schools at Stanford, UC Irvine, and Ohio State are being investigated by the Justice Department? And I'll say, I haven't been with the medical school deans in a while. I know that they're actually meeting now out in Washington, D.C. So I haven't talked to any of those particular deans. This is in a lot of ways about admissions. I'm really confident that RFU is following the law, and that we're doing that we're responsible in terms of making sure that we provide opportunity and don't discriminate and take seriously our mission of making sure that people who have the heart, the will, and the skills have the opportunity to become physicians. And beyond our medical school, pharmacists and podiatrists and nurses and scientists and PAs and all the programs that we have. So, and now I want to return back a little bit to what we were talking about. So I know that about half of the exams that we do have resulted in subpoenas. So when a sane nurse, or you, Julie, I don't know quite where all the parts of the work fall. What happens when you get subpoenaed for following an exam?
I would say that it's fortunately, that has not happened to me yet, although it will. However, it is similar to what happens in a hospital setting where a physician or provider may be subpoenaed to discuss a case or talk about what's happened. In this certain circumstance, and I'm going to let Carrie interrupt me at any time because it is definitely more part of her world than mine. But in this certain circumstance, we really stand by our documentation. As we all learn as clinical providers, that our documentation, if we didn't document, it didn't happen. We are very, very succinct in writing up our conversation and medical history taking with the child. We ask open-ended questions that allow a child to disclose what they would like to or not like to. That's part of trauma-informed care. It's also part of maintaining the integrity of the conversation that we have. And we can defend our difference in information that has been shared within our clinic setting as opposed to in the forensic interview or with law enforcement, based on the way that we document our discussions. And that, I love to say that nursing has always been deemed as one of the most trusted professions, that oftentimes families and children feel more comfortable disclosing to us.
Sure.
And so we are very meticulous in our charting and our notes and documentation about the event. We have systems in place, and fortunately, due to this funding, we have a Cortex Flow camera, which takes very specific, explicit photos that we can really document injury. We can document bruising. We can document microscopic injury in the way that the photo enhances that. And that allows us to be able to save that and create a body map that then describes the injury that we can speak to at the time. I will say these cases go to court, I think, sooner than most typical medical cases. And in that, we have the opportunity to work with the attorneys to review our documentation, to anticipate questions that may come from the defense, and to prepare ourselves. In the same breath, we're really defending our care and describing our documentation and the very methodical way that evidence is collected and this care is performed, especially in a sexual assault case, because it's the sexual assault and the SECETA law that we are following by the book. The physical abuse cases have the same amount of scrutiny, but don't have quite the same stringency in the law.
So, Carrie, I mean, this is having the clinic has been something that you've wanted for a long time. The rooms were put together quite a while ago. We're not the first set of partners that you talked to. What is it about having the medical arm that you thought was so important to the CAC?
Getting these kids served who didn't have access to services previously.
Mhm.
So in 2023, we had approximately close to 600 cases that could have sexual abuse cases that could have warranted a exam, sexual assault exam in various ways. And out of those, we could only track a little over 100 of those cases that were going. When you would tell a family who was leaving here, we need you to go to the hospital, for example, and get looked at. Oftentimes they weren't going. Oftentimes there was a fear. A lot of variables played into them
Mhm.
going and receiving that care. And what we found is that, there was a lot of, again, educational wise, there was a lot of confusion as to that acute versus non-acute. And there's a lot of kids that were missing getting, for example, tested for STDs. I think one of the biggest things that to me has been a game changer with this is that I've worked in the state's attorney's office here for about 35 years. And oftentimes people don't understand the red tape, for example, that you need to go through to be able to get the evidence that is needed for these types of cases. We watch TV and it looks so easy how you get this
Mhm.
evidence, but it often doesn't work that way more often than not. And so what happens is that we would have a case here that we were working on and a disclosure from a child, and we would then send the child, for example, to an ER to get a sexual assault exam. The amount of time that information would be related back to us is anywhere from 4 to 6 weeks. Grand jury subpoenas would be issued for those medical records to be turned over, and there was not that direct communication between the medical exam and the assistant state's attorneys, for example, that were here looking to bring someone in custody. As a result of this medical unit, one of the biggest, in my opinion, wins is that this information and the sharing of information, once that release of information is signed, is right away, resulting in that
Mhm.
people getting picked up and search warrants and or arrest warrants being issued right away. We're able to get these people off the streets quicker. And I think that in itself is a huge piece of information that we often fail to recognize, that, not being able to go perpetrate on somebody else. I think the other piece of it is just that the clients that are coming through our doors don't have the access to just in general medical piece. Julie's team has been able to diagnose children with, AIDS and leukemia and things of that nature that wouldn't have happened before, and being able to have quick access to the medical. And then I think it'd be remiss of me to not acknowledge our law enforcement partners. Here in Lake County, we have over 50 different police departments. And those 50 different police departments need access to medical quickly in these kind of cases. Now they're able to call directly and speak to a medical personnel directly, Julie and her team, ask questions, find out, should this case be coming through you? Is this warrant a sexual assault exam? And being able to talk to that discipline right away. And then being able to work with them on making sure that that child's being brought here and kind of that triaging of what comes first, the forensic interview and or the medical. I think the findings on these cases have been it's a game changer. I think that the relationships that are being built with medical assistant state attorneys, advocates in itself is a huge win. There are so many misconceptions on these types of cases and so much fear of, when I get subpoenaed to testify or what does that look like? And I would say
Mhm.
that what we find specifically in these cases with children who, for example, have been sexually abused is that when all of the information is there and when these kits, for example, are done the right way by the right people with the right experience, they often lead to pleas or cases not going to trial. So what is going to be a very interesting statistic is once we get through some of these cases to see how often was the medical team actually really called to testify, or how often were these cases pleading out because the information was there and it was done accurately. And I think that itself is going to alleviate kids the trauma of having to go to a courtroom. And that data will be interesting when we get to it.
That's fascinating. I mean, one of the things that we talked about on Monday, like I mean, I have a long history of working in, sort of community-based participatory research and, how universities and academics can, look at what interventions are useful and how we can bring them. And my head was full of, questions about that kind of thing, everything from how we, you know, see what happens over the long term. How do we support people? How do we figure out how to engage neuropsych testing? If you think about this as an adverse childhood experience and what those then mean for future health, I mean, like there are just so many different things to work on, but sometimes you have to get to the stuff that's first on the plate. So I just want each of you to just a little bit about like what are you thinking about next as we're working on this, and it could just be we have to get through the week, but maybe Julie, what are you thinking about as we're just getting started at some level? So I completely understand if your goal is to get through the workload, but where's your mind going?
Well, I would say I have grandiose plans. My goal is for Rosalind Franklin to be the medical unit in all of the Illinois CACs. I feel like this is an opportunity for us to bring
Mhm.
this model to all of the CACs so that they can provide this full comprehensive care to each child
Mhm.
that comes in victimized. And so, that it is big. It's also a goal, I think, in well, how I started with increasing awareness, making sure that our colleges, that our future providers have experienced at least enough to have it in the back of their minds. We know that 1 in 5 patients that go in to be seen have had some type of trauma in their lives, whether it's an adverse child event or a victim of violence in their adult
Mhm.
years. We want that to be always on a differential diagnosis. We want them to be able to think about that and to be able to care for the patients that they're seeing. So I feel like grandiose is RFU in each of the clinics. And for the colleges, just increasing awareness for our students and future providers.
Great, Carrie.
I, of course, piggybacking on Julie, but I think most importantly for me with this project is the education of educating your medical students on the work that we do, educating the community on the fact that we exist, and this project in itself has been able to create awareness that we would not have been capable of creating without you. In addition to that, most importantly as well, is that every child that walks through our door has access to medical, and every child that reports physical or sexual abuse that is here in Lake County has access to the proper resources and the proper people with the training that's needed. Certainly not just for a criminal case. That's really, in my opinion, important, but not as high as just being able to alleviate these kids' trauma, to know that their body's okay and that no matter what they've been through, that they're going to be fine. And once they have access to that medical, and the medical says to them, you know what, you're good. You guys, you passed all of the past, if that's even the right word, but your body is
Mhm.
good and you can move on to your healing. And I think that in itself is a huge accomplishment. So I hope that all the children that suffer from this sort of abuse have that sort of access.
Brenda.
I'll piggy on both of you with regard to the education of all of our students. So everyone that walks out of RFU understands what this is and has the opportunity to somehow participate. So I'm thinking more on the granular level of how the medical students can get more involved now that the medical clinic is opened and at the appropriate level of their training. So maybe a 4th-year elective. The other thing, though, and Aaron, you saw this when you were there, because I saw it too, is the opportunities for research. And this is a gold mine because they have the data. They just don't have the time to process that. So if there's a student out there listening now and you're thinking about what's some research project I can get involved in, then come to us because this is a great opportunity. What is your question? We can probably get you the data and we can write this up and start some scholarly activity and making it more publicized to other CACs across the country. And yeah, that's my ideas. So, Jeff?
Well, let me bring it home for what Julie, Carrie, and Brenda have articulated. My job is to be a support structure for our frontline folks, our administrators, our clinicians. My job is to provide some insight and guidance. And so, what I hope to accomplish and, with this program and then beyond is really continue to support our university's mission and what more can we do with this program? I think, we're going to be limited to our own imagination because this can expand to several important, missions for us. And for me, when I like to get involved in introducing new service lines or new initiatives for us, I want it to be meaningful and I want it to be impactful. And I think we have all of those elements here within the university and the folks that that are involved, and that's important for me both personally and for my career.
So, Anonymous asks if there's any ongoing research at the CAC or about CAC RFU outcomes, and Brenda sort of mentioned this, and this is one of those things where it's really important to have a community-based participatory model. So obviously this is an incredibly at-risk population. They've already been exploited once. You got to make sure that if you're asking or working on scholarly questions, that you're doing it with them, not for them or not to them. And that may or may not be easy for us to do. And so, I mean, I think we have to be really thoughtful about what that looks like. On the other hand, there are interesting models. So the 9/11 registry in New York, the Flint water registry in Flint after the water crisis. There's another water registry, I think, in New Jersey. But these are, one part research instruments, but they are mostly making sure people get access to resources. So one of the main things that happens at the Flint Lead Registry is they've done 30,000 referrals to care, mostly neuropsych testing. And there are many interventions that might be useful for families. So leaving the kids out, right? Like what is happening to the loved ones of these kids and what might be interventions, some of which are cheap and easy to do that could be done, at a facility like a CAC, not with the kids, but, with caring adults who are around them. There are lots and lots of instruments that are used in various traumatic situations that might be applicable and just haven't been studied in the circumstance that may or may not work out for us. We would need a different, group of researchers to do that. We would need a group of collaborators. But if Julie's vision comes out, I mean, then we have all kinds of chances and opportunities. So I think the answer is I'm not aware of any of an IRB in existence related to this. There is no doubt lots of practice outcomes data that will being generated, and Carrie mentioned some of the questions they have about how having a medical facility and the same nurses on site, how that changes outcomes. But we'll have to see, and we'll have to, this is one of the things that we can talk to our community friends about. So I just want to thank you all for the work that you're doing, for the opportunity that has come to the university, and maybe for the wisdom and guts to step up and give it a whirl, right? So I just really appreciate that. It's a great project, and all these things always come with their own set of challenges. But I'm just delighted that RFU has stepped up and that the Lake County Children's Advocacy Center has been such a great partner. So thank you, Carrie, for that. And thanks to all of you for being with us. Thanks to Brenda Affinati, Julie Creedon, Jeff Espina, and Carrie Flanagan. Thank you guys so much for all the work. Thanks for being with me here on the town hall.
Thank
And
you.
thanks to all of you for joining us today. Thanks for all you do to support our faculty, our staff, and our students. It is the work of people like you that make the university such a special place to be. It is Friday. I hope you get to have a weekend. Take care, everybody. Bye-bye.